Okay. So it depends on what degree of the ankle sprain has come in. Obviously, if it's 100% tear, there's nothing there to treat. As far as the ligament joint capsule is, you're treating all the surrounding tissue. But if you are treating a first or second degree sort of tear, either 50% and above, I guess it depends on first what your comfortability is with working with those tissues. Now, a lot of research previously has been done and published that showed that typically we don't want to be treating or loading into those tissues until about the 3 to 6 week point. I don't like that. In any of my own personal injuries, I have always loaded the tissue within 24 to 48 hours. I have rehabbed a lot faster. I've seen it done with my elite level Olympic gymnasts, power lifters, football players, soccer players. And now we have the research. So there was a video. I could try and bring it up, but it was from it was just put out recently by, I think his name was Keith Barr, who's a professor of physiology and anyways, he's got a PhD, and this is his area of interest. And his research showed that they start loading the next day. And the very next day, they start loading it within reason, right? So graded exposure, but they start loading it the next day, and they had an ACL reconstruction on a football player, and they had talked to the surgeon. The surgeon's like, "No, we don't want to load until about 6 or 8 weeks." And he said, "Well, why don't we load it like day 6?" And the surgeon reluctantly said, "Okay, well, go ahead, do your protocol, load him at day 6." Well, that player got back to activity a full month before what they were expecting. So with ligamentous articular strain techniques, I like to get my hands onto these acute injuries as soon as possible. If I can get my hands on the next day while it's still acute, we can make amazing effects as manual therapists. So for example, with your fibulocalcaneal ligamentous injury, typically what happens is that there's either an inhibition, a stimulation, or a co-contraction that occurs between tib anterior, tib posterior. Gastrocs will get involved, and it will actually put the foot more into a plantar flexion position rather than a neutral position. And when that happens, your talus actually gets drawn anteriorly. Now, when the talus gets drawn anteriorly, you have a diminished force coupling mechanism, so that when you try and bring your toes to the nose, that talus actually gets pinched on the very distal end anteriorly of that distal tibia. So if we can encourage the talus to sit in more of a neutral position, and we can manage and maintain a normal active range of motion for the calcaneus and for the fibula, then we're going to have better outcomes. The other thing is that when that injury occurred, when that inversion sprain occurred, that fibulocalcaneal ligamentous tissue, it actually pulled the fibula distally away from its proximal attachment. This is why you have semi biceps femoris discomfort and hamstrings protecting and guarding afterwards, because that biceps femoris attaches onto this posterior superior aspect. So we treat the hamstrings, we get the fibula moving, because what will happen is that the hamstrings will try and protect the ankle, like you said, from proximal to distal. It will try and protect by pulling that fibula up into the tibia, and then it doesn't function, it doesn't move. So work on the hamstrings, get the fibula moving, work with interosseous membrane also, which gets into that anterior posterior tib anterior, tib posterior, and then working with the talus and the calcaneus, just to make sure that we keep the range of motion that we have.
Yeah.
So that whole process from the knee to the ankle, that's an hour. We don't go anywhere else.